Hi, everyone. My name is Trace Terrell. I use he, him pronouns, and I'm a junior at Johns Hopkins University, currently studying public health. Today, we're going to be talking about early intervention considerations after a suicide attempt with Dr. Stephen O'Connor from the MIMH. We are so very excited to have him with us today and have a jam-packed program, so we can start to get started. Amazing. For some general housekeeping, this is a reminder to please use the 988 Crisis Jam Learning Community website for all of your crisis information updates and needs. There are so many materials available online, so much great material to cover. And I think most of the crisis jams have been uploaded to the YouTube as well. So they are all archived in that one space for you. We would love if you do check that out and share that with your friends, your colleagues, and other people in the space as well. We're now going to pivot into some of the latest crisis news that is happening. Our first is an article from CBS News that actually features one of my friends, Pooja Mehta. So very powerful as an article, and so lucky to have her voice in it. The title is Decades of National Suicide Prevention Policies Haven't Slowed the Deaths. We had talked before this about how we don't necessarily know if that is possibly the best way to describe it, right? We can't know if the policies that we've already enacted have curbed suicide as compared to if there was nothing at all. So, with that disclaimer, just know that there is still a lot of information in that article. Um, and still, not significantly reduce the rate of suicide overall. We did see last week, however, in our last week's Crisis Jam episode, that the overdose curve is actually bending and there is movement there. That was referenced in our last week's episode, so please feel free to visit that for more information. There's also a CDC report tied to local economic and social conditions as it relates to suicide risk. This is one that particularly resonated with me as I'm someone who has grown up in a rural community and knows that there are a lot of special considerations for people in that area. So just keep that in mind. And we have one more article in the New Yorker. Has social media fueled a teen suicide crisis? This is a really active area for youth advocacy. One of the 98 Crisis Jam hosts, Sophie Chev, actually does a lot of work in that area. I've seen her just completely trailblaze this field. So be sure to check it out for some more information there. I'm now so excited to pass it shortly over to Dr. Ursula Whiteside, founder and CEO of nowmattersnow.org. We are so lucky to have you. She's going to talk a bit about some of the updates over there.
Greetings, everyone. Hi. So glad to be here. I run this website that has been around now for 10 years, and in celebration of our 10-year anniversary, we are launching a new website. If you're not familiar with nowmattersnow.org, it is a website that provides dialectical behavior therapy trainings and skills. And the method of delivery is people who have been there. So this really came out of a desire to help people who were struggling but didn't have access to therapists who taught DBT or were on waiting lists. So this can prove a introduction to dialectical behavior therapy and the skills there. So you can either learn skills or find out if you'd be interested in joining a meeting. Our skills are sectioned into this idea of choices. Which would you like to focus on today? And let's say it's self-care, then you will see specific skills that are associated with self-care. So right now we have about 16, 17 skills up, but we have almost 40 that are near preparation. We're going to be releasing one a week. If you're someone who's interested in joining a peer support meeting where that focuses on these DBT skills, you can find out and learn more on our Join a Meetings tab. So we are super thrilled to do this. A lot of enthusiasm went into this, and lived experience was the basis, the foundation for all that we do. So please follow us on social media to learn more. All of this, of course, is absolutely free. So thank you for having me.
Thank you, Dr. Whiteside. That looks like an incredible website, and I know especially pertinent to young people who might be looking for that. Having a really accessible, interactive website like that is so crucial and so critical. So thank you so much for sharing that with us today. Okay, for our crisis trivia hot seat today, we are going to be doing a brief question. Ursula, are you introducing this? Is that
Go
correct?
ahead. I can do
Okay.
this. Do this. Yes.
Okay, awesome. So I'll read it out for everyone, and there should be a poll that pops out pretty quickly. So for our question, in A Life Worth Living, a memoir, Dr. Marcia Linehan reflects on her personal experiences and the development of dialectal behavioral therapy, DBT. Drawing from both Eastern and Western tradition, she shares how spirituality and philosophy shaped her work. Which philosophical principle underpins the structure of DBT? Is it A, Greek Stoicism, B, Zen Buddhism, C, CBT, cognitive behavioral therapy, or D, Chinese Taoism?
Well, this is very important. This is super fundamental to this treatment. So I started training with Marcia in 1999 as an undergraduate. And well, I know that it is considered a cognitive behavioral treatment, but that's not what makes it what it is. So I'm going to take the CBT off the list. Um, uh, Greek Stoicism, I believe, is often focused on very much like practical effectiveness, and there is certainly an element of that in there, but I don't think that's what it is either. Um, and it does have elements of yin and yang, but I think that ultimately the answer I'm probably going to go with is Zen Buddhism, because she studied in a Buddhist monastery for part of the period while she was developing this treatment. Did I get
Mm.
that?
It- yeah, it looks like the audience has a similar perception. 45% put Zen Buddhism, 30% for CBT, and about 10 and 15% for Greek Stoicism and Chinese Taoism.
Excellent.
Amazing. Thank you for participating in that.
Yay.
It, yeah. Amazing. So, as a short reflection, which is more important? Asked Grand Panda, the journey or the destination? The companions, answered Tiny Dragon. Amazing. I'm now so very excited to introduce Dr. Stephen O'Connor, Chief of the Suicide Prevention Research Program in the Division of Services and Intervention Research at the National Institute of Mental Health. Stephen?
Thank you, Trace. It's my pleasure to be here with you today. Thank you for the invitation. And I'm really pleased also that I get to follow Ursula Whiteside. Really hold her work in high esteem and have known her for a while too. So this is great. Okay, I just want to talk to you today about early intervention considerations after suicide attempt. I want to say from the outset that this is my best take at sharing with you what I learned, but I by no means in the definitive voice on this. And there are some things that potentially I missed and some things I got flat out wrong. But I just, am happy to share with you, what I learned from my experiences. Okay, next slide. So just to let you know, the presentation includes research that I completed prior to joining NIMH, and so the opinions expressed are my own and don't necessarily reflect that of NIH, Health and Human Services, or the US government. And I was fortunate to receive funding by NIH and AFSP and the Louisville Veteran Affairs Clinical Research Foundation as well. Okay, next slide. I just want to start before I get into the actual content by making sure that everybody's aware of a few funding opportunity announcements that NIMH has that are focused on supporting research and crisis response services for suicide prevention. We have one opportunity is for larger studies, and the other is for smaller pilot studies. And these cover really a broad array of everything from clinical trials all the way over to implementation and measuring the impact of state and local policy on crisis services as well. So if you ever want to talk about your ideas related to research that you're interested in pursuing, please reach out to me. And we really are intending the research to be conducted in real world settings and be applicable to a wide range of clinical presentations and psychosocial factors and different intersectional identities as well. So there has been one receipt date that has passed earlier this month. And for the second receipt date, that those are due on June 2nd. We also have a notice of special interest that is going to be active through May 2025. That's not a specific funding opportunity announcement, but it does point you in the direction of active announcements that you could use to support your research and crisis services. And it talks about what NIMH's priorities are in this area. Okay, and then one more slide before we get into the presentation. Peer support services for suicide prevention was something that we were able to host a 2-day scientific focused workshop back in February of earlier this year. And we brought together experts from a variety of different disciplines to try and understand what the state of the science is to inform research and identify the research gaps that exist. So if you have not watched that, you can go to the NIMH website and you can watch an archive. Okay, next slide. So today I'm just going to speak with you a little bit about some considerations around helping someone after a suicide attempt. Again, I am not someone who has survived a suicide attempt, and so there's a big gap in my understanding, I think, phenomenologically of what this really is like for folks. But I did spend better part of a decade working explicitly on this and trying to understand how to improve care that's provided in trauma centers and other settings as well. So the bottom line up front is I think that there's a lot of missed opportunities to incorporate a recovery perspective into the care that's provided for folks after they've survived a suicide attempt. So if you advance real quickly, you'll see an image of a trauma peer visitor that is part of a trauma peer visitor program at Vanderbilt University Medical Center. And so if you survive a motor vehicle crash, someone is going to come by who has also been in that same position and has recovered. They're going to talk to you about what to anticipate. And it is just kind of setting the groundwork, I think, for a positive recovery trajectory. So if you advance one more, I think that the reality for a lot of folks who are admitted to medical surgical floors after they survive a medically serious suicide attempt is that there's this kind of implicit message that you're waiting for permission to start getting better, because there's not a lot that happens that truly is therapeutic, I think, in these settings. And people can stay for, on average 4 days up to 7 days, sometimes longer. But, this could also be applied not just to medical surgical floors, but a lot of other contexts too. And so I think that in general, I think we're really quick to try to do assessments and then try to fix problems, but we're really missing out on understanding, what this event means for someone's own life and how it impacts their recovery. Okay, next slide. Okay, so we can kind of advance through here. One of the things that I spent time was doing, just kind of go through, because there's a number of boxes here that kind of describe someone's journey if they have survived a serious suicide attempt and points in the chain of care within a trauma center where you're going to interact with folks. So we can do one more and then stop right there. Okay, so there's transportation to a trauma center, and there's evaluation and disposition that happens in the ED. If someone's medically unstable, they get admitted to an ICU, to a surgical floor, to a medical floor. And at that point, the psychiatry consult liaison service will swing by, and they are then looking at evaluation and disposition planning as well. And they're in this kind of tough dual role, because I think they're the kind of representatives of the therapeutic experience that's supposed to be provided, but then they're also the folks who are determining what the next step is going to be. And in some cases, someone is really not wanting to go to an inpatient psychiatry unit, and the psych CL service is ultimately sort of they're the ones that are going to help determine this in most states. And then eventually everybody does make their way back out to outpatient services. But what I noticed when I was working on the psych CL service was that there was this really glaring missed opportunity where people were spending a lot of time really just kind of hanging out in their rooms by themselves, not receiving any kind of therapeutic engagement, watching TV, and then I think probably ruminating a lot on. So I came very close to dying. I was fully prepared to die. Now I've survived this experience. So what does this mean for me? What does this mean going forward? And I don't think that there was enough appreciation for actually treating that therapeutically and helping people. Okay, next slide. And so I think the ultimate goal, just across the whole chain of care, not just in trauma centers, is that we are trying to figure out more therapeutic and effective ways to help people, but they really need to be realistic, need to think about what can fit into a busy workflow within any of these settings. That includes mobile crisis, any kind of engagement that we have with people shortly after suicide attempt, and really attending to individual preferences. And from a scientific perspective, thinking about a conceptual framework that it would inform maybe what are the most important factors to consider trying to address with an intervention. So next slide. We can kind of advance through this. This was kind of back in 2010 when I started doing this work, and I found a literature on teachable moments that was mostly applied to smoking cessation. And I took elements of that and thought about it from a suicide attempt surviving perspective. And so this kind of resonated for me with my clinical experience of working with people on the medical surgical floors, was that emotion, it's a highly emotional moment. The perceived risks and positive outcomes, related to the attempts are often kind of intensified. And then the self-concept and social role is really intensified. So I give you an example. Speaking with one individual who was a veteran who survived a self-inflicted gunshot wound to the chest, he felt before he made his attempt that he was going to be doing his family, a favor, no longer be a burden to them. And then when he recovered and regained consciousness, he was surrounded by his family in his room. And he kind of described to me that that was the moment where it really kind of resonated with him that, I am a son, I am a nephew, I am a cousin, a brother. And I really misperceived how this would impact other people. So his self-concept and social role was changed for him. And it's not always the case that people were relieved to survive a suicide attempt. So this isn't like a universally applied, everybody's in this sort of teachable moment window, but a lot of people were, honestly. And so thinking about an article that Ed Boudreau had written where he talked about a teachable moment as being a sentinel event effect. And he said, some of the important factors that would be associated with protection in the near term, they might be different from those, or they might look a little bit different as they progress over time. So I kind of thought about these proximal protective factors related to hope and reasons for living and motivation, and then distal factors of continuing to acquire skills, but then also really being even more deeply engaged in social connection. And I remember talking to Quix Lazine at a conference, an AAS conference, maybe back in 2012, and I wanted to get his take. And I mean, he told me that he felt like hope was the number one most important thing that we could try and convey to people in the near term after they survived an attempt. So that really resonated with me. Okay, next slide. We can kind of go through this real quick, just sort of attending to the time. So I developed something that's called the teachable moment brief intervention. I don't think I created anything new. I think maybe just sort of the way that I put it together and where it's delivered in acute care centers makes it novel. But this is borrowing from work of Marshall Linehan and Dave Jobs. And I, for the first 6 months of my postdoc, I spent up to 8 hours a day with people on medical surgical floors who had survived an attempt. And I'm sort of actively piloting, working with people, trying to figure out what resonated most with them. Tried the CAMS SSF, tried safety planning, tried motivational interviewing. Did a lot of different things and was just trying to figure out like what are you looking for? What would complement what the good care that you're already receiving? And settled upon these different elements. And I think, what I said earlier, I think the emphasis here is not scrambling to try and fix someone. I think that the idea is let's kind of take some time to help figure out why it makes sense that this happened for you. What role has suicide played in your life up to this point? And from your perspective, what's been lost and gained as a result of the attempt? And the gained part is really kind of what have you taken from this experience and how's that informing your recovery perspective as you move forward? So I think that those elements are probably what make this a little bit unique, maybe from some other brief intervention approaches. And we can go to the next slide. So you can read two manuscripts that have been published. The first one reflects the work that I did at Harborview Medical Center at University of Washington over the course of a couple of years, developing the intervention, spending time doing immersive observation, really spending a lot of time kind of saturating. And because I'd worked on the CL service during internship, but this was an opportunity not to be affiliated with them, but to really kind of try and understand the lived experience a little bit better. And then completed an open trial and then did a pilot RCT. And we had positive findings for increasing reasons for living and motivation. But I was the only interventionist in that. So it doesn't really say a whole lot about how this would generalize. So then we could go to the next image. So then I was fortunate to receive funding from AFSP, and that's where I met my colleague who's joined us today, Stephen Nicholson. I haven't seen Stephen in a long time, and I still am so indebted to him for working with me. I was a faculty member at Western Kentucky University, and he was the chief of the Psych CL service at Vanderbilt University Medical Center. And I talked to him about this idea, and he was totally supportive. And so wrote the grant, and we got funding. And in this study, we trained some psychiatry residents, a licensed clinical social worker, and then a graduate student in counseling to deliver the intervention. And a little bit of a voltage drop in terms of the intensity of the progress for some of the outcomes. But we did follow people for a year, and we found that at 3 months, there was kind of this pretty strong signal that people who received this brief intervention were more likely to follow up with outpatient services, and that at 12 months, people who received the intervention were less likely to have returned back to an inpatient psychiatry setting. So, there was some, I guess, some positive things to point to there. But you know what? Then I joined an IMH shortly after that. So that's kind of the end of the story for that brief intervention. But we can go to the next slide. One thing that we were attuned to was the impact that the traumatic experience could have on people and their recovery. I had at the University of Washington, I worked with a psychiatrist named Doug Zatzik, and we ran a separate clinical trial helping people who had early high levels of post-traumatic stress. So kind of thinking about that. So we changed the STEM for the post-traumatic checklist, and we asked people to rate their post-traumatic stress at 1 to 3 months, specifically related to the attempt or the aftercare, the immediate aftercare of going to the hospital and everything that entailed and how traumatic that could be. So we can advance real quick to the next image. And we indeed found that higher post-traumatic stress symptoms were associated with higher levels of suicide intensity and perceived burdensomeness and thwarted belongingness. So if we advance really quickly to the next slide, I think the takeaway for me, and I know that I'm speaking to leaders in the field, so I'm not telling anything you don't know, but really emphasizing a recovery perspective, that it should be emphasized and supported at every step in the recovery process. And would really like to see healthcare try to frame a suicide attempt as a part of a person's personal journey and understanding what historically that's going to mean for someone as they move forward in their life versus the way that I think that it's typically presented to folks. And I just think about the way that, that impacts how people make sense of their own experience and how they think about themselves. So there's a lot of opportunity that we could do better. And focusing on strategies of recovery that complement those that most of the interventions in my portfolio are so completely focused on like reducing suicide attempts or reducing suicide intensity. And I feel like they're kind of missing this other really important, crucial aspect of people's experience, which I wrote into a NOFO that I published, the NIMH published shortly after I arrived, that emphasized reducing risk, following acute care by enhancing perceived social supports and connections that contribute to life-affirming beliefs, intentions, and behaviors. So that language was written into that NOFO. And I'm excited because Jennifer Lockman was funded by this notice. And she's one of the discussants today. And her work, I think, is really kind of capturing the spirit here of, some of the things I've talked about and what we were hoping to fund. So I will stop. There might be one more slide, basically just saying thank you. So that's my backyard in Shenandoah National Park. I'll stop there. Thank you. And I think we have some discussants.
Thank you so much for that incredibly rich presentation. We're so lucky to have you on today, and thank you again. For our roundtable, we have Dr. Jennifer Lockman, who's the Assistant Professor of Psychology at the University of Alabama at Birmingham. And we also have Dr. Stephen Nicholson, Director of the Psychiatry Consultation Service at Beth Israel Deaconess Hospital in Massachusetts. Very excited to welcome them both to this conversation. And Jennifer, we can start with you first. Curious on initial impressions or thoughts on the presentation.
Sure, absolutely. Well, thank you so much for the chance to be here today, and I appreciate the invitation from all of you. I just wanted to share a little bit about my background in terms of my perspective of where I'm coming from, because I think that shares with the group the perspectives that I bring, but also potential biases or blind spots, which I think we all have to be recognizing in our community. I am a counseling psychologist by training, and and I'm currently working as an assistant professor at the University of Alabama at Birmingham in our Depression and Suicide Center. My background also is very connected to nonprofit community mental health. I served as the CEO previously of Centerstone's Research Institute, and also as their chief scientific officer, and oversaw components of the evaluation for zero suicide programs there. And so all those things taken together, with where I am now, I have a burgeoning research program on suicide recovery. We are actively studying what it means to recover from suicide, both clinically and personally. We're looking at mechanisms and processes by which how people recover and how that may vary by different things over time. And we're also thinking about clinical implications. How do we spark recovery and motivation for recovery, when and how to do that, and in what ways that best meet people's needs. From a research perspective, when we think about the research and recovery and kind of where Dr. O'Connor's work and presentation fit in here today, I think we first have to acknowledge that it seems to me, just in my opinion, that we are at an inflection point in suicidology in terms of really starting to look at recovery in a more research-focused way. I think it's always been a shared goal. I think if you look at any treatment that has been developed so far, if you talk with people in the field who've been working in it for a long time, I think we have this shared understanding that helping people recover has always been an aim. However, as Dr. O'Connor pointed out, it's not always been what we've focused on or what we've focused on clinically early on in care. And people with lived experience tell us that. We see in the Way Forward report, for example, more calls for clinicians to really think about personal recovery and what that means. Being able to perhaps start that sooner. I have a very dear colleague who works in our research lab, Dr. Bree Banks, who's been very open about her own lived experience along with training as a suicidologist. And she always tells us, not dead is not good enough. A lifetime of suffering with repeat assessment or management of risk by itself, just really, we have to do better. We have to really meet people where they are, and we have to offer hope in the context of what recovery means, and being able to start that as soon as people demonstrate readiness. So I think in that context, Dr. O'Connor said that he doesn't think his work is novel. I think I would beg to disagree, truthfully, because I think a lot of our historical programs think about recovery later. there's this sense sometimes, for example, that we have to develop sufficient levels of skills to then be able, for example, to have a life worth living, or that we need to stabilize the suicide crisis, medically stabilize the person. Then perhaps later we can talk about recovery or a post-suicidal life or a life worth living. I think Dr. O'Connor's work was one of the first, to show us that recovery can start right away and that most people are able to do that. And that was a finding that we also found in the our AFSP funded clinical trial for Thrive, which is another brief intervention we developed that focuses on recovery. And so we found that most people, over 94%, were able and ready to start talking about and directly working on their personal recovery from the very first conversation. And so I think we have much more to learn as a community about, how and when to help people recover. How and when we can help focus on mechanisms of recovery and how those may be similar to or different from suicide drivers, and how we can help every single person map out their own recovery trajectory. So just one more thought that I wanted to share is that, I think this work also illustrates that the importance of reflection. Dr. O'Connor said our goal in that moment is really, the idea is not to fix someone. And I think that's so important, that sometimes when we come with, traditional but important in their own right risk assessments or like physical, papers and forms that we want people to fill out, especially perhaps for people with chronic suicidal ideation experiences or attempts or multiple attempts, the feeling of that we hear from people is that it may or may not be helpful. Some may find that very helpful when it's done very empathically and with a strong alliance. Other people may have that sense of, you are trying to fix me in a way that I don't perceive that I can or want to be fixed in this moment. And so really, I think the spirit of this intervention is, at which we have also used, by the way, at UAB on our medical surgical floor with positive effect and in our inpatient hospital. The idea of coming to someone and say, tell me your story. Let's understand this together. Let's think about together the gains and losses of this experience and what that means for next steps in your treatment. I think it is very meaningful, to be able to do that work with the idea of common understanding, the idea of mapping out next steps as you see them and what help you do and don't want from the treatment team on that, and letting people be in the direction seat of their own life, which is sometimes a critical piece of what's missing. So together, I do think this is a very meaningful intervention. We use it at UAB actively, and I think we have a lot more work to do and to do together in terms of really focusing on suicide recovery as much and as possible as people are ready and able, and letting them be in the driver's seat of that.
Thank you so much, Dr. Lockman. That was very, very insightful. I'd like to now invite Dr. Nicholson to provide a few thoughts. Amazing. Welcome.
Well, yeah, thank you very much, Stephen. Good to see you. And thanks for having me. I'm a psychiatrist who works in the hospital. They call us consultation liaison psychiatrists. So I don't work in a psychiatric facility, but rather a general hospital. And so we see a lot of patients who have had suicide attempts, and usually, or as we are trained, we're supposed to answer about 3 questions. 1, does the patient who's just had a suicide attempt, are they still at risk for harming themselves? 2, do they need any particular medication for either substance withdrawal, depression or psychosis, those type of things? And then 3, does the patient need to go to a psychiatric facility once they are medically stable? And so these questions are kind of that we're trying to, can we fix the patient, make them not suicidal right now? And as Stephen mentioned, this is the way people are usually treated in a general hospital, and it's we're missing a chance to really engage with the patient. And that's why when Stephen told me about his brief intervention, I thought this is a really great idea, because we have these patients and we're not really giving them more tools while they're here in the hospital. And so the brief intervention that Stephen taught us helped us be able to create a framework to help the patient derive some meaning from the suicide attempt and the treatment experience afterwards. And I think it really put the patient in a position to learn how to manage future crises better. So as Stephen mentioned, we used several trainees on this study, and they universally really loved the intervention because it gave them a framework besides that medical framework that I just mentioned, where we're answering these basic questions, but rather it gave them a way to uncover some meaning and learn about the patient and help the patient learn about themselves. So we found it to be very helpful, and it fit well in the hospital despite being very different from kind of traditional medical and psychiatric treatment.
Thank you so much for that. I believe we are running over on this, so we might have to move on. But if anyone in the audience has any questions, please feel free to populate the chat with them. I'm sure we would still love to hear those, and others in the audience would appreciate them as well. If we could also do a virtual round of applause for our incredible presentation and roundtable discussion. That was so insightful for me as a student, and just so grateful to have had that here today. We're now going to move on to some partner updates. Wonderful. Our first is from Dr. Laura House, who's the Engagement and Equity Officer for the 988 Behavioral Health Crisis Coordinating Office. I believe you're on mute.
Thanks so much. Good afternoon, everyone. It's so nice to be here today in Crisis Jam. I wanted to bring a few updates on behalf of the 988 office at SAMHSA. The first update is that the FCC put out a final rule for geo-routing mandates that they will vote on tomorrow at their October meeting. And what this requires is that all carriers will go live with geo-routing for voice calls for 988 within 2 years of the effective date. So that's the first bit of news or update that I wanted to provide. And I'll put the link in the chat for more information regarding that. In addition, I wanted to share with you that we went live for 2 of 3 major carriers recently, and we're pending a launch date for the 3rd carrier. So we're happy to announce that as well. And then I also wanted to share with you, and you may know, that we launched a streamlined version of the pre-chat survey, and we also updated the 988lifeline.org website. And what that has done is to double the number of people that we can connect to care using chat. So we're also quite excited about that as well. In addition, we have some webinars that are coming up soon that we wanted to share with you. We have on November 14th, our Children, Youth, and Family webinar series. We have a webinar entitled Understanding Children, Youth, and Family Services Across the Crisis Continuum. It's session 2 of that series, and it's on November 14th from 2 to 4 p.m. Eastern Standard Time. In December, we have 2 webinars, and the first is one that I am doing with our Embedding Equity team, and that's entitled Budgeting for Equity, and it's going to be on December 3rd from 11 to 1 p.m. Eastern Standard Time. And then finally, we have a webinar focusing on older adults, and it's called Older Adults and the Behavioral Health Crisis. Older Adults in Behavioral Health Crisis. And it's scheduled for December 12th at 2 p.m. Eastern Standard Time. And so we invite all of you to register for those sessions and join us to learn more about 988 and how it's affecting different communities and populations. That's it for me in terms of updates. I'll make sure that I put the link regarding the FCC ruling in the chat for everyone.
Thank you so much for those updates. I know those are all so helpful for everyone in our audience. So really appreciate that. I'll now turn to Dr. Deborah Pienaars, Senior Medical and Forensic Advisor and Editor-in-Chief at the National Association of State Mental Health Program Directors. Just I think I got that right.
Yeah, thanks. Hi, everybody. This is Deb Peinels. I'm really excited to be here at the Crisis Jam moment for NASHBID. I just want to talk about something that we're really excited about. We can go to the next slide. In partnership with SAMHSA, SAMHSA released the Connected and Strong series that you've heard me speak to before, the compendium of 10 papers, 10 technical assistance papers that are meant to help facilitate the field's work in advancing services along the continuum of care, with this theme focused on crisis and mental health services, of course. We can go to the next slide. So there's 10 of them, like I said, all sorts of topics, and I'll just highlight a few of them. We have, we can go to the next slide. For example, the opening paper that speaks to the whole Connected and Strong series and the Biden Unity Agenda that talks about strengthening system capacity, connecting Americans to care, and supporting Americans by creating healthy environments. You can read about some of the leading ways that we believe that the system is advancing in this space in the crisis continuum. Next slide. And in the sixth paper is another one that I'll just highlight. We're looking at how to leverage strengths and opportunities in the field of 988 and 911. Writing this paper was a labor of love for those of us that were part of it. And I really want to thank Belina Shaw and Thiessen over at SAMHSA for helping us guide us in this work. But in this paper, there's a lot of discussion about what is the definition of interoperability, interconnectedness, integration, collaboration, coordination, and then just what you all need, which is an acronym dictionary, because there's so many new acronyms in the field that we're not familiar with. So there's a lot of great resources in that paper. Next slide. Just to highlight in the seventh paper, it's data related to facilitating rapid access to outpatient mental health and substance use care. Clearly, we need for crises to be prevented and for people to get referred to access to outpatient care. And we see data presented that shows most people who did not get needed mental health or substance use care experience negative impacts, predominantly personal relationships and job issues. And that paper's full of ideas and data that all of you will be interested in. Next slide. This one is the ninth paper, which talks about intersectionality of faith, mental health, and community partnerships. And we worked with NAMI and others to help craft this paper. And you can see quotes from some faith leaders. It's imperative for faith communities to create environments where pastors feel safe and supported in their own seeking of help. And then in the next quote, the fact that pastors are trusted voices within their communities and already provide comfort, counseling, and resources make pastors logical mental health champions. So it's really bridging across non-traditional partners and bringing in the faith-based community. Next slide. And the last paper that I just put a little spotlight on, my colleagues and friends, Amy Brinkley and Justin Volpe, helped lead this paper to its completion. And really, it provides a host of resources for people interested in peer support services across the crisis continuum. For example, guidelines on what peer support workers should do and what they perhaps should not do, and some discussion related to that. So these slides will be available as we always provide them to you through the Crisis Jam. Next slide. And you already see the link in the chat, but just so that you know, you can just Google or use whatever search engine you prefer, Connected and Strong in SAMHSA, Connected and Strong in NASHBID. And as always, if you have any questions, please feel free to reach out. We are really excited at NASHBID to partner with SAMHSA and to see that these papers get out to the field. And we hope that you'll take advantage of them and that they will be helpful, and love to hear feedback as we look at next paper series that we're producing. And that's it for me, Trace.
Thank you so much, Dr. Peinels. I'm curious quickly, what do you think are some of the next steps we can take to kind of get those out into the field and disseminate them um, in the right places at the right time? And especially like what can young people do, right? Because I think this is so critical. I know a lot of my peers are wanting to be involved in this space as well. And so if there's anything that we can do to help, I'd love to learn and take that and share it with some of my colleagues.
Yeah, well, first of all, definitely just pass out the links and the papers, make people aware of what they are. And again, you know, I've shown them in my own space in different committees I sit on, different work groups that I'm with. I talk to legislators and I pull up papers that are relevant. There's certainly papers in the series. If you go back, this is part of a larger, we call it the Beyond Bed series that started in 2017. But these 10 technical assistance papers that SAMHSA has produced every year in partnership with NASHPID, many of them are youth focused too. So looking on the website, looking at the NASHPID and SAMHSA websites, you'll find many other themes from prior years. And we're working on forthcoming papers as well. Many of them have a youth focus. And so these are just the 10 that were recently released, but there's a whole series that comes behind it and will continue to evolve.
Thank you so much. That's very, very helpful to know. Wonderful. For now, we will move on to our How It Feels section. And we are going to invite Day Catalano, the TA Research Associate at NASHPID, and Erin Milligan, Injury Prevention Section Chief at the Substance Misuse and Injury Prevention Branch at the Arkansas Department of Health.
Hi, thank you so much for that introduction, Trace, and for the opportunity to talk with y'all about the innovative work that Arkansas has been doing in the 988 and peer spaces. So my NASHPID colleague, Christy Malik, and I had the pleasure of interviewing Erin Milligan, the Injury Prevention Section Chief, and Ashley Costa, the Suicide Prevention Program Manager with the Arkansas Department of Health, which oversees the Arkansas Lifeline Call Center. So as you may know, there have been a lot of interest lately and recently about proactively incorporating peers into crisis services, including 988. And after hearing that Arkansas has actually been doing this work since 2020, we were elated to have the opportunity to learn more about their impact by sitting down with Erin and Ashley, who were the first two peers to bring their lived experience to Arkansas's team. So today we do have Erin joining us. So it's really great to see you again, Erin. I hope you're doing well.
Good to see you.
Thanks. So during the interview, you shared that your lived experience helps you connect with others who are experiencing similar situations. Would you mind telling us a little bit more about that and how it can be used as an asset for 988 contacts?
Well, I believe that from my personal experience, when someone is trying to help me, when they have an understanding, I'm not saying they understand completely what I'm going through, but have some sort of understanding what I've gone through, what I'm going through, how I'm feeling, I'm more open to talking to them about exactly what's going on in my life. And I've felt that that was a really nice asset to have within the call center, especially when it came to people with substance misuse or, feeling suicidal. And I've been with both, 7 years in recovery now. I just celebrated on October 2nd, 7 years actually. And like just being able to connect with somebody because all of a sudden they're like, oh, you've dealt with that too. And that just opens the door. So definitely connection is key.
Definitely. And would you mind talking a little bit more about that connection and how it helps you with kind of building that rapport and that relationship with the person you're talking to?
So whenever I'm able to give my experience, my strength and my hope on, the fact of what I've gone through, the steps I took to overcome it and what my day-to-day life looks like now in recovery, that gives people the opportunity to kind of tell me what it is that's going on. And, we work through the steps together on how they want to be successful in recovery, and what that process looks like. What resources do I need to provide to them? do I have enough knowledge in the resource that I'm providing to them? Do I feel comfortable giving them that resource and them asking me, well, have you used this before? Or do you know somebody who's used it? And there's a lot of people in the recovery community here, especially in Little Rock, Arkansas. Thank you, Mary, that have used plenty of resources. So I can always, ask my friends and now what I call family, have you used this or that? And then give them a definite answer instead of just sending them to a resource that may or may not work for them.
Awesome. No, I can definitely see how that would bring so much value and to that relationship that you're building with them and just helping them to understand that, these resources do work and this is how, and having that firsthand experience for sure. And in the article, you also did mention how incorporating peers has been beneficial for help seekers, but that it's also been really beneficial for other crisis counselor staff on the team. So would you mind sharing a bit more with us about that?
So I believe that it breaks down walls. For a very long time, I think either, feeling suicidal or dealing with substance misuse has been a kind of a taboo subject, especially here down in the South. And so breaking down those barriers and, trying to remove the stigma, our recovery community has grown so much within the past 7 years that I've been active. And, now people are starting to have the conversation. Like they're no longer embarrassed to say, hey, my family member is struggling with XYZ. How do I help? Or I'm struggling with XYZ, even though I may work in a hospital setting. I don't want, my coworkers to know, or I work, in a government setting, and I don't want my coworkers or my boss to know, like, what can I do? Because there are people from all different walks of life that are finally coming, to surface and saying, well, this is where I'm at and I need help. So breaking the stigma, most definitely. When I came here, I was kind of scared, intimidated to be working with people who I thought, just had no clue what my life was like, when in reality, they've either had a loved one who struggled or, everybody was young once, so they might have dabbled here and there. Like it's not as taboo as I thought it was. And people are so loving and with open arms and are willing to listen to my story. And if they have things going on in their personal life, are willing to come to me and be like, hey, I need help with this.
Awesome. Well, thank you so much, Erin. As a former crisis counselor myself, it was really inspiring to hear about the work that you and your team have done to really elevate the value of lived experience, not only in your 988 work to better support help seekers, but also the rest of your team. So just thank you so much again. And with that, Crisis Jammers, we encourage you to read the Crisis Talk article. The link should be in the chat, but if not, it will be momentarily. And with that, we'll turn it back to you, Trace. Thank you.
Thank you for having me.
That was absolutely incredible. Thank you both, Day and Erin, for such an insightful presentation. I'm also like a former crisis interventionist, and hearing that there is some change there is so impactful and powerful, and just so grateful for the work that you're doing. If everyone wants to maybe drop a learning they had from that conversation in the chat, that would be wonderful. Just kind of share out any takeaways or insights, any ideas that you can kind of take with you outside of our space today. Very excited to now transition to our strong talk segment with Vic Armstrong. Very, very excited. Vic, we are so excited to have you here today.
Thank you so much. Stigma is a mark of shame or disgrace. It's a barrier both to care and recovery for individuals living with mental health and addiction challenges. But perhaps a deeper understanding of why stigma exists, how it develops, and why it may look different in historically marginalized communities is warranted, and would help us launch a much more targeted initiative. Stigma is essentially a narrative, albeit negative. It is a narrative that is shaped and shared by a community. Its origin is often explicitly to breed division, separation, and establish hierarchy, but stigma can also arise out of fear, ignorance, or collective trauma. As a young Black male, I was socialized to navigate the world with my head down and my mouth closed. I learned from my community that it was dangerous to acknowledge mental or emotional pain because, God forbid, you should be viewed as weak or vulnerable, and that Black men in particular are devalued when viewed as flawed mentally, physically, spiritually, or emotionally. It was not a hard narrative to accept, given the history of people who look like me in America, and given that my narrative was left unchecked by the experts in the field. There was no narrative outside my community that challenged my community's narrative. Stigma was given room to breathe. I was taught in my community that my ancestors survived slavery because of resilience and faith, not because of access to mental health care. I heard countless messages about the power of prayer, but never of therapy. In fact, I distinctly remember singing along with the choir on Sunday morning, Jesus on the main line, tell him what you want. Not clinician on the hotline. I still carry the memory of my grandmother singing and humming the words, as long as I got King Jesus, I don't need nobody else. And rather than today's mantra of it's okay to talk, I heard what happens in this house stays in this house. Stigma became normalized, in part because it was a convenient narrative, but in part because it filled a void. I can still hear the words of a family member who reached out to me confiding that he had learned some time ago while serving 16 years of a 31-year prison sentence for a horrifically violent crime, that his erratic behavior, including his criminal past and subsequent suicide attempts, had been due in part to a diagnosis of untreated bipolar disorder. But he chose to keep silent about the diagnosis because he would rather be labeled as criminally violent than mentally ill. That is the power of stigma. Stigma campaigns and slogans and catchphrases can be effective. I utilize them myself, but it is imperative that we realize that when it comes to communities, it is difficult to change perception without acknowledging the origin of that perception. And it's difficult to erase stigma without addressing the trauma that birthed it. Sometimes stigma is something much more than a mark of shame. It is sometimes a cry of, I matter. It is sometimes a way of expressing, I choose to be here. I choose to live. And I will do so the only way I know how, even if it kills me. And that is strong talk.
Goosebumps. Thank you so much. Thank you so much for sharing that. As you were speaking, I actually added it to my Spotify list. So make sure to please check out the Strong Talk podcast. That was absolutely, absolutely incredible.
Thank you so much. Thank you so much. I appreciate that.
Of course, of course. In our last few minutes together, we will be discussing some of the upcoming events. Next week, episode 195 will be on DOJ and mobile crisis with Jennifer Mathis. And the week after that, we will be talking with NashBid on their workforce resource guide with Wendy Morris. So make sure to tune in for both of those if you aren't already. As a reminder, you do have to sign up and be authenticated on Zoom. And in December, very excitedly, there will be a debate for peers working in crisis care with 3 really incredible people leading that conversation. So very excited to be there for that. And please make sure to tune in. And for all of us here today and for those who will be watching later, thank you so much for joining this community. We are so appreciative of you and for the time and dedication that you have for this cause. So thank you so much. It is really inspiring to young people like me to know that there are so many people working on it now. So thank you. Thank you for watching.